Welcome back to another board review video in which I go over some practice board review questions and talk you through my step of the process every step of the way. A 54-year-old man is brought to the emergency department by his wife due to 2 days of progressively worsening confusion and high-grade fever. Oral exam shows severe gingivitis with some oral ulcers. The rest of the exam is unremarkable. Lab results show a white count of 1.5, which is low, absolute neutrophil count of 300, hemoglobin and platelets look normal, and then triglycerides and all of the lipid panel is relatively unremarkable, mildly elevated. So of this, we can basically already tell that this is going to be a question about neutropenic fever because of the absolute neutrophil count of less than 500. Again, neutropenia is absolute neutrophil count of less than 1500, and less than 500 is severe neutropenia, which is when people are at the highest risk for developing neutropenic fever. So I wouldn't be surprised if this is a patient who is like a chemo patient or something and ended up getting very neutropenic, and that's why they're coming in. So which of the following is the most likely diagnosis? Metabolic syndrome, agranulocytosis, serotonin syndrome, delirium, and neuroleptic malignant syndrome. So actually, this is not what I was anticipating them to ask. But I guess if they're asking for the diagnosis here, we can kind of go through, metabolic syndrome is not going to cause a leukopenia with a fever. Agranulocytosis causing an isolated decrease in your neutrophil count and your white blood cell count totally could make sense, especially if he's on various medications which can cause agranulocytosis, such as I'm thinking like methimazole is one of them, carbamazepine is another classic one. Serotonin syndrome is not going to cause this either. Delirium is not going to cause this, and neuroleptic malignant syndrome is not going to cause the leukopenia. So really, agranulocytosis has to be the top of our answer choices here. So he has a known history of schizophrenia. His wife reports that his mental health has been stable for the past 3 years. His past medical history is significant for hyperlipidemia. His weight has increased from 90 kilograms to 78 kilograms over the past... his weight has increased from 198 pounds to 172 pounds. That looks like a little bit of a typo there. BMI is 28. And he is on Clozapine, which is a very classic medication for causing agranulocytosis as well. And he's neutropenic. So this is obviously agranulocytosis. No question about that one. Neuroleptic malignant syndrome. So let's think about how that would present. Typically, they're going to be on multiple antipsychotics. They're going to have muscle rigidity and fever. So that lead pipe rigidity. But in this case, he's got the fever, but he doesn't have those other signs on physical exam. And he's got this neutropenia, which totally fits with agranulocytosis. All right, let's move on to the next question. So a 52-year-old man with a history of glioblastoma presents to the emergency department with altered mental status and twitching. A stat head CT is ordered. Which of the following is the most appropriate next step in management? Midazolam infusion, oral prednisone, oral metoprolol, IV dextrose, and IV lorazepam. So let's see. He's weak on the right side and right arm clonic activity is noted. So this seems like he's having what they now are calling focal onset seizures. They used to be called like complex seizures and partial seizures, but now it's called a generalized seizure versus focal onset with impaired awareness or with intact awareness. I forget what the exact terminology is. So let's read through. So it's going to be a treatment that's, treating seizures, which is most likely going to be one of the benzodiazepines. IV dextrose would be if he's hypoglycemic, which he's not. We can tell here already he's not hypoglycemic, but hypoglycemia can definitely cause focal onset seizures. Metoprolol would have been like if this is some kind of benign twitching, essential tremor or something, you want to get them on like a beta blocker potentially. Prednisone, if we're thinking there's some swelling in the brain, but typically we use dexamethasone for that. So I'm definitely thinking about one of the benzodiazepines here. And typically we start with IV benzodiazepine. And then if it's, refractory, we'd probably go on to something more like a Versed drip like this. So his wife notes he was tired last night from chemotherapy, but was otherwise acting appropriately. This morning she woke him up and he was not making sense. On the way to the hospital, his right arm started to jerk intermittently. His blood pressure is 165/83. Vital signs otherwise unremarkable. He's aware of his surroundings, but cannot answer questions and just repeats the word no. So I think we would probably start with just an IV benzodiazepine to see how he responds to that. rather than starting with a Versed drip, which typically patients are going to have to be like intubated at this point if they are on a Versed drip. And this is not obviously my strong suit. Neurology cases almost always go directly to the neurologist at like a large academic center. But I'm pretty sure about this one, and it is the correct answer. So this is going to be the first line medication for status epilepticus. It's going to be a benzodiazepine followed by a second dose of benzodiazepine and then a loading dose of IV fosphenytoin. Infusions should only be started after several doses of benzodiazepines and IV anti-seizure medications have been ineffective. All right, and I have an Anki card actually on the steps of escalating therapy for acute seizure. So it's going to be benzos, IV anti-epileptic like Keppra or fosphenytoin, and then an IV anesthetic. So you can see here, first line, here's your options. Lorazepam, diazepam, midazolam, just push. And then you get into your anti-epileptics, and then you're going to be doing an IV anesthetic with intubation and then doing like one of these drips. All right, let's move on to the next question. So a 75-year-old woman presents to the clinic with severe persistent pain on the left side of her chest that started following a herpes zoster outbreak 6 weeks ago. So right now I'm immediately thinking, is this going to be like a cardiac type of chest pain, or is this going to be related to the herpes? Now you can have very prolonged pain after a shingles outbreak or a herpes zoster outbreak. And so that's probably what I'm leaning towards right now. That's probably why they're asking this question is like, can you still have pain 6 weeks after? Now, if you think about things like trigeminal neuralgia, you can get this like persistent trigeminal neuralgia pain, like postherpetic pain. And so I think very likely you could have this on your chest as well. Physical exam shows crusted over remnants of blisters in a dermatomal distribution. Minimal erythema is noted. Her most recent labs were shown, and she had a creatinine of 2.2, which she has a chronic kidney disease history, and a hemoglobin A1C of 7. So these are kind of some risk factors for some coronary artery disease potentially. But I think, the fact that it's very much related in timing to the recent shingles outbreak, and the fact that the pain is burning and sharp is causing sleep disturbances. Typically, cardiac chest pain is going to be described as that pressure-like pain on exertion, so when they're doing activities or walking around, not while they're just lying in bed and causing like a burning sensation. So which of the following is the best treatment for this patient? Amitriptyline, capsaicin cream, gabapentin, prednisone, and oxycodone. Okay, so this is not where I was thinking this question was going to be going, but let's see if we can try and reason through this. So oxycodone is an opioid. That's not going to be good at treating neuropathic pain, which is what the pain of a herpes zoster outbreak is. Typically, oxycodone is more for nociceptive type pain. Prednisone would be just like a generalized anti-inflammatory. Typically, it's not something we reach for straight away for just like treatment of pain. Now, gabapentin, capsaicin cream, and amitriptyline, all of these can be beneficial in neuropathic type of pain, although capsaicin cream, I'd say less so. Capsaicin cream, I typically think of like bony pain can be really good for, or malignancy. But, the side effect of capsaicin cream is a burning sensation, right? It's just the hot peppers sensation. So that can be useful for distracting people away from pain that they're having. So actually, it may be more of like a nociceptive pain treatment because it's distracting them from whatever pain they're already having. So I would say capsaicin cream, let's just put more burning on top of their burning. I don't think that's going to be the right answer. And then amitriptyline versus gabapentin, the way I'm going to choose between these two is that amitriptyline tends to be like a more long-term therapy, whereas gabapentin I can think of as like more shorter duration. They can use it during this interim period where she just needs a little bit more pain control. And so we will go with that one. And trying to see if there's any other contraindications. She's got CKD, so we're going to have to dose reduce it based on her kidney function. But I'm pretty sure the answer here is going to be gabapentin, and that is the correct answer. So gabapentin is a first-line agent for postherpetic neuralgia, and it's especially appropriate for this patient because of her severe persistent pain on the left side of her chest. The dosage would need to be tailored accordingly due to her chronic kidney disease. TCA, amitriptyline, is a viable treatment option, but it is not the best choice for this patient because of a higher side effect profile, including anticholinergic effects, especially in an older patient like this one, and exacerbating underlying cardiac conditions. All right, we're doing well so far, so let's move on to the next question. A 58-year-old man presents to the outpatient clinic with a 4-week history of worsening epigastric pain, early satiety, and a 10-pound unintentional weight loss. So definitely very concerning, the worsening pain, early satiety, and weight loss all makes me think of some kind of potentially like a malignancy going on. He has a history of H. pylori gastritis, so he's also at higher risk for malignancy. EGD reveals an ulcerative lesion in the distal part of the stomach near the pylorus. Biopsies are obtained and lab results reveal the following. I'm interested in what this picture is going to be showing. Looks like a little bit of hyperpigmentation going on in the axilla. Hemoglobin is low at 11.8, which makes sense with the recent gastritis. And then the platelets and the white count is relatively, they're within normal limits. So let's see what the answer is here. What is the most likely diagnosis? Extranodal marginal zone B-cell lymphoma of mucosa-associated lymphoid tissue, or MALT. This is definitely associated with H. pylori, but the patient's already been treated for it. He treated it 6 months ago. So I feel like this is probably a little less likely, although definitely has an association with H. pylori. And one of the things that we do when we treat this MALT lymphoma is you need to treat the H. pylori. So you just treat it with PPI and antibiotics. And then eradication of H. pylori infection is associated with a high rate of response and long-term remission for these tumors. Regression of the lymphoma occurs slowly, so serial endoscopy will be needed to document the response to therapy. Gastric neuroendocrine tumor, I think this is also less likely because that would just be kind of unrelated to this patient's chronic gastritis. I think they have higher risk factors for potentially some other malignancies, unless they just really got unlucky and just happened to have this happen. We've got metaplastic atrophic gastritis. That's usually talking more about like B12 deficiency or like that autoimmune kind of thing. The parietal, antibodies, what's that called again? Metaplastic atrophic gastritis, which is due to antibodies against parietal cells and leading to decreased production of intrinsic factor, which I believe binds that vitamin B12 and allows you to absorb it. So anyways, that's less likely. Gastric adenocarcinoma, definitely very likely here. And a GI stromal tumor, I forget the association for this one, but I think it's less likely. I think this patient just has the highest risk for a gastric adenocarcinoma. I mean, these are all kind of just unrelated. So let's see. He eats a diet high in processed meats and low in fruits and vegetables, denies alcohol consumption and any family history of GI malignancies. Vitals all look pretty good. And then he has this skin finding here. So the only thing here, I don't know what this is associated with. I'm actually a little bit unsure about this now because it must be associated with one of these malignancies, but I don't know which one it is. So yeah, I'm actually not sure. Gastric adenocarcinoma probably wouldn't present that quickly also. Atrophic gastritis is not going to cause like an ulcerative lesion. Maybe it's a GI stromal tumor. I feel like after being treated for H. pylori, it's still not going to be MALT associated, but MALT, maybe it's associated with the skin finding. Neuroendocrine tumor, maybe it's associated with this. Shoot, I'm not really sure about this one. I'm just going to go with GI stromal tumor. I really don't know the answer on this one. I really don't know. Let me know what you picked in the answers down below. And it was gastric adenocarcinoma, so my gut was correct. I just convinced myself out of it. So I guess acanthus nigricans is often associated with underlying malignancies, particularly gastric adenocarcinoma. So I actually did not know that gastric adenocarcinoma could be associated with acanthosis nigricans. So can gastric adenocarcinoma be associated with acanthosis nigricans? Yes, often associated. Okay, so yeah, I convinced myself because I was thinking maybe it's related to one of these other ones that I just didn't know, but it does not. All right, next question. A 58-year-old woman comes to the clinic with a 6-month history of progressive painless swelling in her left upper extremity, as well as occasional numbness. There is non-pitting edema from the hand to the shoulder. The skin is thickened and has a peau d'orange experience. Sorry, a little hard to pronounce that. And there are no signs of redness, warmth, or tenderness. Which of the following is the most appropriate next step in management? So she has had a left-sided mastectomy and axillary lymph node dissection for breast cancer 2 years ago, and she also wears a compression sleeve regularly. So are we treating this chronic lymphedema with steroids? Probably not. For complete decongestive therapy, probably not until we do some more conservative measurements first. Diuretics, probably not, because generally volume depleting her is going to fix the lymphedema issue that's like localized. And then pneumatic compression therapy, I do know that we do this for lymphedema in the lower extremities. So this is probably the correct answer. and then refer the patient for a surgical lymph node transfer. I don't know anything about that. So I think we're going to start with something a little bit more conservative. And I'm actually wrong. And 75% of people got this right. Complete decongestive therapy. So initial management of lymphedema includes limb elevation, upper body exercise, skincare, and a graded compression sleeve. They should avoid using the affected arm for procedures such as vaccinations, blood draws, and blood pressure measurement. And then when these conservative measures are not sufficient, CDT is an often effective treatment, but requires a high degree of patient compliance. It involves several interventions, including manual lymphatic drainage, a form of massage that reduces swelling, compression therapy, therapeutic exercises, and skincare. So I did not know about that. So pneumatic compression therapy, it sounds like it is an option, but it's for people who are not able to do CDT, and it's often less effective than CDT. Okay, and the last thing I wanted to mention is that this avoiding using the affected arm for procedures such as vaccination, blood draws, and blood pressure measurements. I recently had a patient who had bilateral mastectomy with lymph node dissection, and so neither of their upper extremities were supposed to be used for blood draws and blood pressure measurements. And so it was making it really difficult to get IVs in this patient and then do blood pressure cuffs. So I actually looked into the evidence of not doing interventions, and it is recommended to avoid them if possible. But if you really have no other option and you need to, for example, get a blood pressure there or get an IV there, it does seem like it's okay. So let's see. Is it preferred to avoid IVs in the upper extremity of a patient who had mastectomy on that side? Yes. If absolutely needed, though, it's likely okay. If you look at the evidence, it seems like it's kind of recommended, but it's not the most dangerous thing if they get one IV. But maybe surgeons may have some more experience with seeing this severe lymphedema, and they may have something more to comment on regarding that. So 2 questions wrong already, unfortunately. Let's see if we can pick it back up, you guys. A 56-year-old woman is in her primary care provider's office for a routine evaluation. She has a history of hypertension and rheumatic fever, so she's immigrated from somewhere, most likely. Auscultation of the heart reveals a normal S1 and S2 and a holosystolic murmur that radiates to the axilla. Which of the following is the most appropriate diagnostic study at this time? Cardiac catheterization, mitral valve scoring, blood cultures, transthoracic echo, and cardiac MRI. I think really the first thing to start at would definitely be just get an echo, see what that valve looks like first of all, and then maybe we could do some of these more invasive things afterwards. There are no recent hospitalizations, but she did have endodontic work about 2 weeks ago for a sensitive tooth. No fevers, chills, night sweats, any other symptoms. Vital signs look good, no JVD, and lungs are clear to auscultation bilaterally. Her PMI is 2 centimeters wide and located at the 5th intercostal space, 3 centimeters left of the left mid-clavicular line. So it sounds like it's laterally displaced, and usually that's a sign of volume overload from what I remember, although this is PMI is not something that I typically really check for. So I think we're just going to start with an echo for this one, and that's 89% of people got that right. An 82-year-old woman presents with new onset pain over her right buttock. Immediately I'm thinking, could this be some kind of sciatica or something? There's a small amount of blood staining her gown and the sheets on her bed. Dorsal pedis and posterior tibial pulses are present, so vascular-wise seems to be intact. Nails blanch with pressure. They don't really comment on her capillary refill, but it's normal if the nails blanch with pressure. Monofilament testing of the feet shows normal sensation, and Achilles, patellar, and branchial reflexes are present. Which of the following types of ulcers is most likely? Pressure-induced, neuropathic, arterial, venous, and inflammatory. So pressure-induced is going to be somebody with diabetes, and it's going to be on locations that could have a lot of pressure, like your heel or your medial malleolus or something like that, because these patients with diabetes and neuropathy, they're not able to feel that there's too much pressure there, and so they don't readjust. Normally, people kind of readjust their pressure every now and then. But in this case, she had normal monofilament testing of her feet, argues kind of against having a diabetic neuropathy, so that's less likely. Neuropathic ulcer, I'm not totally sure what that is, so let's skip that one for now. Arterial ulcer is going to be typically at the very, very distal areas of your foot, for example, your toes, and you are going to have signs of poor perfusion. For example, bad pulses, very poor capillary refill, which we don't really seem to see here. So I'm going to do less likely for that, and I actually don't know where her ulcer is yet. We'll see if they tell us that. And then venous ulcer is going to be more kind of where your edema is. So if you've got edema in your calf, for example, you tend to get things kind of on your ankle and a little bit higher for venous ulcers. So we'll see if that could be it. And then looks like she's got abrasions and ulceration over the right buttock. Okay, we're going to have to read a little bit more to see what's going on here. So 3 weeks ago, she was transferred to a rehab facility following repair of a fractured left hip. Her mobility is significantly limited due to pain, and she spends most of her time in bed. Her past medical history is significant for heart failure, hypothyroidism, essential hypertension, ischemic heart disease, and type 2 diabetes. So she's got a ton of medical comorbidities. This is very common in our patient population. Recent right hip arthroplasty and cholecystectomy. She's on a bunch of meds. She's got S3 gallop, so she's got some volume overload. She's got a holosystolic murmur. She's also got mitral regurgitation like that last patient. And then lungs show decreased breath sounds at the bases. She has mild pretibial edema without cyanosis or clubbing. So yeah, I mean, venous is definitely an option, but typically we don't think about venous ulcers in your buttock. Typically pressure-induced is going to be the ones that are like buttock and sacral ulcers. And she's had reduced mobility because of this recent hip surgery. So it's probably pressure-induced if they haven't been moving her enough. And then venous, she's got a bunch of signs of volume overload, but the location is just not typical. And she has mild pretibial edema. It's not like she has very severe edema. So again, typically we think of pressure-induced as like diabetes patients on their foot, kind of over like bony areas. Arterial, we think about the distal toes, and then venous, we think about like kind of the ankle area. But in this case, she's got like a buttocks ulcer, right? I didn't realize it was going to be a question about buttocks ulcers. So I'm going to go with pressure-induced ulcer here, and 94% of people got that. Yeah, so here you can see the different locations. So you got your venous ulcers here on your calf. This is going to be very typical. And then arterial ulcers is going to have like very poor perfusion, typically more in the distal areas. And then your neuropathic ulcers is the pressure type ulcers that I was referring to, which is kind of like your diabetes ones over the like bony areas. An inflammatory ulcer is something like pyoderma gangrenosum, something related to a systemic inflammatory disease. All right, let's do one last question. This is a short one, looks like. So a 22-year-old woman presents to the clinic with a 3-week history of persistent cough, night sweats, weight loss, and low-grade fever. Sounds like TB. She was studying abroad in India. Sounds like TB. She appears fatigued and has diminished breath sounds. Sounds like TB. A chest x-ray is performed. Which of the following is the most likely finding on chest x-ray? So does she have curly B lines? That's congestive heart failure. And a 22-year-old? No. Interstitial lung disease? Does she have like some kind of autoimmune history? Pulmonary fibrosis? For this young of an age, she probably would not. And we're not getting crackles, kind of like that Velcro sounding crackles. Right-sided pleural effusion, she has something in the right upper lobe. We would hear diminished breath sounds in the lower lobe if she had a pleural effusion. And then a right upper lobe consolidation. Does she have just a typical pneumonia? Probably not, given that it's been going on for 3 weeks. She's got B symptoms. So we're going to go with cavitary lesion, and she's got TB. All right, that was pretty easy. So let's do one more. A 72-year-old woman with metastatic breast cancer presents to the clinic complaining of worsening dyspnea over the past week. She's got a large right-sided pleural effusion. Which of the following is the most appropriate next step in management? Palliative chemotherapy, non-invasive positive pressure ventilation, furosemide, home oxygen, or immediate thoracentesis? And the answer is going to be immediate thoracentesis. Anybody with a new pleural effusion has to be drained, and you have to send it for studies. Especially, this is most likely a malignant pleural effusion. If this was bilateral pleural effusions and she had a history of heart failure, then we typically do a trial of diuresis first. But in a patient with known metastatic breast cancer, this is almost certainly malignant pleural effusion, but you got to drain it, and then you have to see how quickly it reaccumulates. And then afterwards, you're going to think about more palliative measures depending on the status of her cancer. So she's winded with minimal exertion. Her vitals all look good, except she's tachypnic and she's hypoxemic, and then breath sounds are decreased. So yeah, you just got to do a thoracentesis right here. 89% of people got that right. These are all pretty quick. So not only does therapeutic thoracentesis provide immediate symptomatic relief, but the fluid obtained can be sent for cytological analysis to confirm malignant involvement. And so again, if it's like draining, if it's reaccumulating very, very quickly, one of the things you can do is called a tunneled pleural catheter or a Pleurix catheter, which would be something that you kind of leave in there, and then patients can drain it on their own at home. The problem is you really should only do that in like kind of palliative care situations because, it's an indwelling thing and it's an infection risk, things like that. A 35-year-old woman presents to the clinic for a follow-up appointment after being diagnosed with asthma 6 months ago. She is interested in understanding her risk factors for asthma exacerbations and potential long-term consequences of her condition. Which of the following is the most predictive of increased risk for future exacerbations in this patient? Comorbidity, recent exacerbation, sex, family history, and adherence to therapy. So clearly, we want people to be adherent to therapy, but I am thinking that might be a potential answer. Family history and sex, I don't think would be an indicator of increased risk of future exacerbations. Comorbidity definitely could. Recent exacerbation, I'm thinking probably could play a high role here. She's been compliant with her prescribed fluticasone and albuterol, has hypertension. So she doesn't really have that many comorbidities. So what comorbidities would we be talking about? She had one asthma exacerbation in the past 6 months. So I think the recent exacerbation is probably the highest risk factor because we know that people who have uncontrolled asthma are going to be at higher risk for having future asthma attacks. And so that is the correct answer. All right, I hope you guys enjoyed this board review question session. Had some interesting questions and some quick ones towards the end there. Please let me know down in the comments below if you have any questions. Thanks again for watching, and I'll see you in the next one. Peace.